Welcome to the Deep Dive, your shortcut to being truly well-informed. You might think this deep dive into horse liver health is maybe just for the vets out there, but honestly, it's packed with incredible insights for anyone fascinated by the sheer resilience of these magnificent animals and, the amazing complexity of their internal systems. Today, we're plunging headfirst into the intricate world of equine liver health. Specifically, we're zeroing in on two significant conditions: hepatic abscesses and cholangiohepatitis. All right, it's time to pull back the curtain on some of the most intricate challenges equine vets face. We've compiled a mountain of research on these two conditions, and our goal today is really to unravel their complexities piece by piece, so you gain a crystal clear understanding of what's really going on when a horse's liver is in trouble. Let's start maybe by defining our terms. So when we talk about a liver abscess, we're looking at a localized collection of pus right within the liver tissue. Typically, the result of a bacterial infection. Think of it like a walled-off pocket of infection. Cholangiohepatitis, though, that's different. It's a more widespread inflammatory condition. It involves both the bile ducts, those tiny tubes carrying bile from the liver, and the surrounding liver tissue itself. So inflammation in two key areas.
Yeah, and what's truly fascinating here is the prevalence. You see, while discrete hepatic abscesses are considered uncommon in horses, ascending septic cholangiohepatitis is actually quite common.
Oh, really? That's a big difference.
It is. And this isn't just a fact, it's a critical insight for diagnosis. The takeaway here is that if a horse presents with sort of vague liver-related symptoms, cholangiohepatitis is often the first thing vets consider. It guides their initial path because it's just more likely. An abscess, on the other hand, might be a more elusive puzzle. And when we look at signalment, which is simply, the common characteristics like age or sex, cholangiohepatitis is most commonly diagnosed in adult horses. It doesn't really show a strong age or sex preference beyond that. Focal abscesses, however, they're more sporadic. They can affect foals, for example, often from a rhodococcus infection or maybe an umbilical vein infection, sometimes called navel ill. But they can also show up in adult horses, sometimes linked to other issues like tumor necrosis.
Okay, so understanding what these conditions are is step one. But the real challenge, I imagine, especially for vets, is actually spotting them. You said the signs can be sneaky. So what clues should we be looking for? The signs for both these conditions can often be pretty vague, right? And overlap a lot, which, as you mentioned, reflects the liver's large functional reserve. It can take a lot of damage before showing obvious signs. Common indicators for both include weight loss, often chronic, and sometimes the only sign, especially with abscesses. You might also see intermittent or persistent fever, signs of abdominal pain, colic, but basically general lethargy, depression, and a loss of appetite or anorexia.
Exactly. And we connect this to the bigger picture. While those signs are common, there are key differentiators that help vets narrow it down. Jaundice or icterus, that yellowing of the mucous membranes like in the gums or whites of the eyes. That's more consistently present, often more pronounced with cholangiohepatitis. That's because it primarily involves the bile ducts and affects bile flow directly. With liver abscesses, it's less consistent. It might only appear if the abscess is very severe or causing some kind of obstruction. Photosensitization, that severe sensitivity to sunlight causing skin lesions, it's common when there's significant cholestasis.
Yeah.
Impaired bile flow, basically.
Right.
You can see it in both, but again, more frequently with cholangiohepatitis.
And what about neurological signs? I've heard of horses having kind of brain issues when their liver isn't working right.
Exactly. Hepatic encephalopathy. That's essentially brain dysfunction caused by toxins building up because the liver isn't clearing them properly.
Right.
It can manifest as worrying neurological signs like head pressing, aimless wandering, uncoordinated movements, ataxia, blindness, even seizures, or just a general stupor. It's less common with focal abscesses, unless they're really large and causing widespread liver damage. But it can occur with severe liver damage in either condition. In really severe cases of cholangiohepatitis, you might even see fulminant hepatic failure. It's at a rapid, severe decline in liver function. Life-threatening.
That sounds serious.
It is. For focal hepatic abscesses, the signs might be much simpler, maybe just general ill thrift. They just don't seem to be doing well, look unthrifty, and, as you mentioned, sometimes colic.
It's always fascinating, I think, to understand the why. Where did these significant problems even begin inside such a magnificent animal? What are the root causes?
Well, for cholangiohepatitis, it's primarily thought to be the result of what we call ascending infection.
Ascending.
Yeah, ascending. It means bacteria, usually common gut bacteria from the duodenum, that's the first part of the small intestine. They essentially climb up the bile ducts into the liver.
Wait, so they actually climb? That sounds like quite an active process for bacteria. And you
Yeah.
mentioned there's generally no historical intestinal disease. That is surprising. So it's not like the horse had a bad gut infection that then spread.
Precisely. That's one of the puzzling aspects. It's often an opportunistic ascent, not necessarily a direct consequence of a pre-existing severe gut illness. This inflammation of the bile duct lining, the epithelium, combined with enzymes released from these bacteria, it can actually cause calcium bilirubinate calculi to form, bile stones essentially.
Bile stones, okay.
And any kind of bile stasis where bile flow slows down or stops, or an obstruction, maybe from those colits or gallstones,
Bro.
or inflammation of the duodenitis, immune parasite migration, or a tumor, all of those things really predispose horses to cholangiohepatitis. Makes it easier for the infection to take hold.
Okay, that makes sense. And what about the discrete abscesses? Different story.
Often, yes, a different origin. The most common route for them is hematogenous spread.
Hematogenous, through the blood.
Exactly. Bacteria traveling through the bloodstream. Think of it like bacteria hitching a ride on the horse's internal highway system, its bloodstream to get to the liver. This can happen via the portal vein, which brings blood directly from the abdominal organs. So if there's an infection like enteritis, colitis, peritonitis, or even, say, a ruptured bowel, bacteria can travel to the liver that way.
Ah, okay.
Or it can be via the hepatic artery from a systemic infection somewhere else in the body, like pneumonia or maybe a heart valve infection, endocarditis. In foals, as we touched on, a specific route is umbilical vein infections, navel ill, which can sometimes extend directly into the liver, and then more rarely, abscesses can stem from, widespread infections, sometimes specific bacteria common in younger horses like rhodococcus or streptococcus, or parasite migration, even local vascular issues causing tissue damage. Lots of possibilities, really.
Wow, that's a lot of potential paths for infection. It really underscores how complex the horse's internal systems are, doesn't it?
Absolutely. Their physiology is remarkably intricate, and these conditions are a clear demonstration of that complexity.
So, given all these potential causes and the often vague signs, how do veterinarians actually diagnose these conditions? What's the diagnostic journey like? How do they uncover the truth?
Well, the diagnostic journey really starts with suspicion. For a horse presenting with colic, marked jaundice, and those elevated liver enzymes in their blood, vets immediately think of cholangiohepatitis. But they also consider other possibilities, like a twisted colon or maybe even a tumor. These are the differential diagnoses, other things it could be.
Right, ruling things out.
Exactly. Now, what's nearly pathognomonic, meaning it almost definitively points to cholangiohepatitis, is when you have that colic, jaundice, and elevated liver enzymes, plus a fever. Leukocytosis, which is an increase in white blood cells indicating infection, and elevated serum globulin, a type of blood protein often linked to chronic inflammation. Put all that together, and cholangiohepatitis is very high on the list. Blood work, specifically a CBC, complete blood count, and a biochemistry panel provides critical clues. For cholangiohepatitis, you'll typically see marked elevations in an enzyme called GGT, usually over 300 units per liter.
GGT. Okay, that's a key one then.
A very key one. There are usually less marked elevations in other liver enzymes like AST, SDH, and GLDH, which indicate liver cell damage. Importantly, you also see elevations in conjugated bilirubin, sometimes making up 50% or more of the total bilirubin increased serum bile acids and those elevated serum globulins we mentioned. The CBC often shows a mature neutrophilia, more neutrophils, a type of white blood cell with maybe a mild elevation in plasma fibrinogen, another inflammation marker. But GDT and ALP, alkaline phosphatase, are typically markedly elevated. Those are the key indicators of cholestasis, that impaired bile flow.
And for the abscesses, is the blood work different?
It can be, yes. For discrete hepatic abscesses, you might only see mild elevations in GGT, often without significant increases in those other hepatocellular enzymes or bilirubin. Neutrophil counts in the blood are generally increased, sometimes dramatically, especially with rhodococcus equiabscesses in foals. Blood fibrinogen and globulins are also generally up, though they might be normal if the abscess is related to, say, a tumor or that rhodococcus infection. And you might see signs of chronic liver dysfunction like hypoalbuminemia, low albumin protein, and decreased BUN.
That's a lot of blood markers to track, but it sounds like they paint a pretty specific picture when combined. What about actually looking at the liver, imaging?
Absolutely. When it comes to imaging, ultrasound is really the most definitive, non-invasive diagnostic tool. It's incredibly useful here.
So what does it show?
For cholangiohepatitis, ultrasound might reveal distended bile ducts. Happens in about 60% of cases. Sometimes you could even see calculi, those bile stones appearing with acoustic shadowing behind them, or sludge, which shows up with acoustic enhancement. You might also observe subjective hepatomegaly, basically. The vet thinks the liver looks enlarged. And in long-standing cases, you'll often see increased echogenicity. That means the liver tissue looks brighter on the ultrasound, which indicates fibrosis or scarring.
Ah, scarring.
Yes, and bile duct dilation is a really characteristic finding for cholangiohepatitis.
And for the abscesses on ultrasound?
For focal abscesses, their echogenicity, how bright or dark they look, is variable. Depends on their stage. But keep in mind, you can only see a small percentage of the adult horse liver with abdominal ultrasound. You can see more in foals, though.
Right.
For foals, if discrete lesions are suspected, CT scans can sometimes be used for liver imaging, too.
Beyond imaging, are there other tests?
Yes. The most important invasive diagnostic procedure is a needle aspirate and biopsy.
Taking a sample directly from the liver.
Exactly. This is crucial. You get samples for aerobic and anaerobic culture and sensitivity testing, finding the bacteria and what kills them, and for microscopic examination. Looking at the cells themselves, it can usually be performed safely using a special biopsy needle with ultrasound guidance, but like any invasive procedure, it carries minor risks, like hemorrhage or maybe bile leakage.
Makes sense.
And if an obstruction of the common bile duct is suspected, sometimes duodenal endoscopy, putting a scope into the duodenum, might let the vet actually see a stone or a bulge where the duct opens.
So once a diagnosis is finally made, what's the road to recovery look like? It sounds like a complex problem, so I imagine the treatment often requires a pretty long-term commitment.
It absolutely do. You're
Okay.
right. Antimicrobials are truly the mainstay of treatment for both conditions, antibiotics. Long-term appropriate antibiotic therapy is crucial, and ideally it should be based on those culture and sensitivity results from the aspirate or biopsy we just discussed.
Right, targeted therapy.
Precisely. Oral antimicrobials are often preferred for long-term treatment. We're talking 3 weeks to maybe 6 months for cholangiohepatitis and weeks to months for abscesses.
Wow, that is long-term.
It is.
Huh.
Several drugs have been used successfully. Common ones like trimethoprim sulfa, enrofloxacin, metronidazole. Sometimes injectable antibiotics like ceftiofur or gentamicin are needed initially. If the culture results are inconclusive or you can't get a sample, then empirical therapy might be started. That means treatment based on what's most likely causing the infection, and then you adjust based on how the horse responds clinically.
Are there surgical options?
They're generally secondary options. For cholangiohepatitis, surgery might be considered to remove obstructing calculi if medical therapy isn't working.
Yeah.
But surgically removing large obstructive bile stones in horses is technically very challenging and carries significant risks.
Tricky surgery, then.
Very. For focal hepatic abscesses, if one happens to be in a surgically accessible area and medical management fails, sometimes a rib resection can be done to allow surgical access for draining the abscess. Large abscesses or infected umbilical veins in foals should also ideally be drained or removed surgically.
And what about supportive care? Just helping the horse feel better.
Oh, absolutely vital. Hospitalization might not always be needed unless, say, intravenous fluids are required for dehydration. Icteric horses, the ones with jaundice, should definitely be kept out of direct sunlight until their bilirubin levels normalize. That's to prevent photosensitization.
Ah, right, the sun sensitivity.
Exactly. A normal diet can usually be fed. Hepatic encephalopathy, the neurological issue, rarely occurs. But if there's a risk, a high-carbohydrate, low-protein diet is generally advised. NSAIDs, like flunixin meglumin, are used for pain and fever, of course. And sometimes liver protectants like SEMA or silymarin are used, though their proven efficacy in horses can be a bit variable. Worth discussing with the vet.
That's a really comprehensive approach. What's the outlook for these horses once treatment begins? What's the prognosis?
The prognosis, well, it really varies. For septic suppurative cholangitis, the prognosis is generally good with medical therapy if there are no obstructing calculi, and the liver's ultrasound appearance, its echogenicity, is normal. Surprisingly, horses with very high GGT levels, even over 2,500, have recovered successfully.
That's encouraging.
It is. However, the prognosis is poor if there's already severe fibrosis, that's scarring we mentioned, or irreversible liver damage present on biopsy. For liver abscesses, the prognosis is generally guarded to poor. It really depends on their size, number, and location. Early diagnosis and aggressive, prolonged treatment offer the best chance. A very serious complication is rupture of an abscess into the peritoneal cavity of the abdomen, which is often fatal, unfortunately.
That sounds dire. How is progress monitored?
Good question. For follow-up, clinical improvement, the horse looking and feeling better is typically seen before those GGT levels fully normalize. It's recommended to continue the antimicrobials until GGT returns to a normal range, or at least gets below about 100 UL. And after stopping antibiotics, another GGT measurement is advised just to make sure things remain stable. For hepatic abscesses, follow-up ultrasound is definitely recommended to monitor the lesions themselves, see if they're shrinking.
That summary really crystallizes the differences. It sounds like while the symptoms might trick you initially, a vet's ability to differentiate these really hinges on those very specific diagnostic markers, especially in the blood work and the ultrasound findings. It's truly a testament to the precision needed in veterinary medicine. So what does this all mean for you, the informed learner?
Let's just quickly highlight the most important differentiators between these two conditions again, because they might present similarly, but they are distinct, and recognizing those distinctions is key. Absolutely. Let's boil it down to distill the most important distinctions. First, the primary lesion is different. Remember, it's a focal, contained collection of pus for an abscess.
Right, like a pocket.
Exactly. Versus diffuse, widespread inflammation of the bile ducts and the surrounding liver tissue for cholangiohepatitis, much broader. Second, jaundice or icterus. Less consistent with abscesses, but more consistently present and often more marked with cholangiohepatitis because it directly messes with bile flow.
Okay.
Third, and this is a really strong indicator, GGT and ALP enzyme elevation. Might be normal or only mildly up for abscesses, but they are markedly elevated, showing that clear cholestatic pattern for cholangiohepatitis. That's a huge blood test clue.
Got it. Markedly elevated GGT-ALP points towards cholangiohepatitis.
Generally, yes. Fourth, bile duct dilation on ultrasound. Not typically a main feature for abscesses, but it's a characteristic finding for cholangiohepatitis. And you often see those bile stones. Colics with it too. Fifth, their pathogenesis, how they develop, differs. Hematogenous spread, bloodborne, often via the portal vein from gut infections, is most common for abscesses. While that ascending bacterial infection from the gut and bile stasis are the main drivers for cholangiohepatitis, different routes in fact. And finally, the best culture source, usually an aspirate directly from the abscess for abscesses, but a liver biopsy, specifically getting tissue from the bile ducts and parenchyma for cholangiohepatitis. That tells the vet exactly what bacteria they're fighting.
That brings it all together beautifully. This deep dive truly underscores the importance of a thorough diagnostic workup, including that comprehensive blood work, the abdominal ultrasound, and especially that ultrasound-guided liver biopsy and culture, all needed for accurate diagnosis and ultimately successful treatment. And remember, as we heard, long-term antimicrobial therapy is absolutely paramount for both conditions, along with tailored supportive care.
You know, this deep dive into equine liver conditions really highlights the liver's incredible capacity for resilience, but also its absolutely critical role in overall health. It does raise an interesting question, though. How do these specific pathways of infection and inflammation in horses mirror, or perhaps differ from, liver diseases in other species, or even in us, in humans? It's a fascinating cross-species comparison to think about.
A great thought to mull over, and definitely something to keep in mind as you encounter more information on health across the animal kingdom. Keep exploring, stay curious, and thanks for diving deep with us today.